Welcome to part 2, positive pressure ventilation. Now the objectives for this session are just to consider the primary indications for commencing positive pressure ventilation, PPV, examine respiratory failure type 1, which is oxygen failure and the related mechanisms, and then review respiratory failure type 2, which is to do with ventilation and the related mechanisms again. And then just consider the types of mechanical ventilation interventions that are available. What are the primary indications for commencing positive pressure ventilation? Well, the indications are primarily severe hypoxia. Despite oxygen therapy, you've got a PaO2 of less than 60 millimeters of mercury. And in conjunction with a low arterial peripheral oxygenation, which can be measured with pulse oximetry using SpO2, less than 75%. Or severe hypercapnia or hypercarbia, indicating a high arterial CO2, which is typically indicated by an arterial blood gas with a PaCO2 of greater than 60 millimeters of mercury. And these can be in combination. However, on physical assessment, you could also see that there was excessive work of breathing, and based on clinical signs, the patient may require positive pressure ventilation. Type 1 respiratory failure is oxygen failure. This is severe hypoxemia. Despite being on oxygen therapy, they have an arterial blood gas with a PaO2 of less than 60 millimeters of mercury and an SaO2 of less than 75%. Causes of type 1 respiratory failure include pulmonary edema, pneumonia, acute lung injury, atelectasis, gastric content aspiration into the lung, a pulmonary contusion, any form of acute pneumonitis, a pulmonary embolism, and there are more. Mechanisms for hypoxemia include a low inspired oxygen, hypoventilation, impaired gas exchange, a ventilation perfusion mismatch, or right to left shunting. Type 1 respiratory failure, which involves a low FiO2 or hypoxemia, can be related to altitude sickness. You're at Mount Everest, no oxygen. Asphyxiation, you're being strangled. Smoke inhalation, near drowning, a foreign body airway obstruction, strangulation. The X-ray that you're looking at indicates right main bronchus obstruction, which is resulting in decreased air entry into that right lung. Type 1 respiratory failure related to hypoventilation. Hypoventilation can be caused by anything that decreases air entry into the lungs for gas exchange. So for example, if you've got chest trauma or a chest injury, this is going to result in hypoventilation or tachypnea to begin with, but eventually the pain will have an effect. And the effect will be one of splinting, and eventually it will result in hypoventilation. Type 1 respiratory failure, impaired gas exchange. Gas exchange can be impaired by anything that decreases gas exchange between the capillaries and the alveoli. So for example, acute respiratory distress syndrome is one of the worst or one of the most severe respiratory conditions that causes impaired gas exchange. The chest X-ray is demonstrating it perfectly. You've got increased whiteness globally throughout the lung fields, but the patient, if you saw the patient in the physical area, they would have severe respiratory difficulties. Type 1 respiratory failure, a ventilation perfusion mismatch. This is anything that causes ventilation, which is air entry into the lungs, and perfusion, blood flowing through that area of lung where gas is wanting to be exchanged, mismatching. So for example, here in the diagram that we have is one of acute pulmonary embolism. You've got normal breathing, however you've got abnormal blood flow. You've got air entry into an area of lung, but because there's no blood flow, there's no gas exchange. This is an example of ventilation perfusion mismatching. Type 1 respiratory failure, right to left shunt. This is one example of right to left shunt where blood goes through the lungs without gas exchange. And if there's no gas exchange, this is a form of dead space, which means it doesn't participate. So the example that we're looking at here is pneumonia. You've got right middle lobe pneumonia, the area of whiteness. So therefore this area of whiteness could be tissue, collapse, consolidation. It doesn't participate in gas exchange because air cannot enter that area, which is why it's referred to as ventilated dead space. Here's type 2 respiratory failure. And type 2 respiratory failure is related to the ventilatory pump failure. And the purpose of the ventilatory pump is, yes, to provide oxygen, but it's also to eliminate CO2. And this is indicated by a PaCO2 of greater than 60 millimeters of mercury in a normal person. I mean, if you've got chronic lung disease, then the criteria may change. You may also have hypoxemia, where the PaO2 is less than 40 millimeters of mercury and the SaO2 is less than 75%. So it could be a combined situation, but typically respiratory failure is to do with the CO2 removal. What are some of the causes of type 2 respiratory failure? Well, anything that affects CO2 removal. So it could be the mechanics, the pump. And the pump is controlled by the central nervous system or the brainstem. So you could have central nervous system depression such as a drug overdose, a head or a brainstem injury, a spinal cord injury, any form of neuromuscular or a neuropathy of some kind. You may have a kyphosis, a scoliosis, or a kyphoscoliosis. It can also be affected by the increase in load, and the increase in load refers to too much CO2. So if you've got chronic obstructive pulmonary disease, or COPD, then you've already got an increased load in CO2 which has to be removed. And if by some chance you get a chest infection, this may cause respiratory failure. You've other chronic lung diseases such as cystic fibrosis, chronic bronchiectasis, chronic bronchitis, emphysema, even asthma could be indicated. What are some of the mechanisms associated with ventilatory failure or type 2 respiratory failure? Well, we're talking about hypercarbia or hypercapnia terminology. And this can, as I indicated, be associated with hypoxemia. So the mechanisms are hypoventilation, central nervous system depression, as a result of possibly a drug overdose or a head injury. Then you've got ventilatory failure, the mechanics, the thoracics, the thorax. It's not working properly. So you may have a chest wall abnormality as indicated by the kyphoscoliosis, scoliosis, a number of muscular disorders. Or it could be related to a neuromuscular disease. Then you've got diseases that increase your dead space, such as chronic obstructive pulmonary disease, a pulmonary embolism, pulmonary vascular disease. Here's an example of chronic obstructive airway disease where you've got increased dead space. And this chest X-ray is showing us a huge emphysematous bullae, and as a consequence of that, the alveoli don't really exist functionally, and you have poor CO2 removal. Tuberculosis, another chronic lung disease. You've got increased dead space as a result of fibrosis and lung damage. You have poor gas exchange, which could result in a high CO2 or CO2 retention. Cystic fibrosis, another one, related to increased dead space, fibrosis, poor gas exchange. Here's an example of scoliosis, and as a consequence of mechanics of the thorax being impeded, chest wall abnormality, ventilation may become ineffective. The chest X-ray that you're seeing here, you've got a rod implanted by the probably an orthopedic surgeon in an attempt to decrease or limit the malformation of the spine and the chest. There's also a tracheostomy there, so this must be a very chronic condition. So what are some of the recommended interventions to support breathing in these patients? And we're not looking at them in any great detail, we're just looking at them briefly. Part 3 of this course here will provide with more information. So the therapeutic interventions could include oxygen therapy, bronchodilators to open up the airways and promote gas exchange, recruiting manoeuvres such as non-invasive mechanical ventilation, CPAP, continuous positive airway pressure, BiPAP, bi-level positive airway pressure, also referred to as non-invasive pressure support ventilation, or this might require intermittent positive pressure ventilation, which could be non-invasive or it can be invasive after having been intubated and ventilated. But this will require, in some cases, intubation and invasive mechanical ventilation. So therapeutic interventions include oxygen therapy, bronchodilators for patients now that have, for example, asthma, or they may have an allergic reaction to something which has resulted in airway obstruction, bronchoconstriction. Now you've got non-invasive positive pressure ventilation, and this is where a mask, nasal prongs, the mask can be partial or full, but this is where air or a mixture of gas is pushed into the lungs through the airways. And because it's being pushed by the machine, this creates a positive pressure in the airways. It's being forced into the airways. Non-invasive positive pressure ventilation can include, as I indicated previously, CPAP or BiPAP. CPAP is an acronym or an abbreviation for continuous positive airway pressure. BiPAP is an acronym or an abbreviation for bi-level positive airway pressure. CPAP has one pressure, BiPAP has two pressures. So during inspiration and expiration, CPAP provide the same positive pressure. During inspiration and expiration, BiPAP provides an IPAP, an inspiratory positive airway pressure, and an EPAP, an expiratory positive airway pressure. Then you've got more invasive interventions, such as intubation with an endotracheal tube or a tracheal tube, or a tracheostomy tube, depending on what the situation was, or what the patient's condition is, or how long the ventilation may be required for. Then we move on to invasive positive pressure ventilation. And as I indicated previously, this is using a tracheal tube of some kind, whether it's endotracheal, nasopharyngeal, oropharyngeal, or a tracheostomy tube going directly into the trachea. In this situation, or in this intervention, air or gas mixture is pushed into the lungs again through the airway. And because it's being pushed by the machine, which is a pump, a ventilator, it creates a positive airway creates a positive pressure in the airways. Mechanical ventilation, invasive, also referred to as positive pressure ventilation, employs an adjunct called PEEP, positive end expiratory pressure, which promotes airway opening during expiration to prevent lung collapse, and it enhances gas exchange as well. So the take-home message here is basically, again, as we indicated in part 1 of this program, healthcare providers must be knowledgeable, sure. They must have an idea of what they're doing, but they must ensure that the caring, when caring for these patients on mechanical ventilators or airway devices, that the caring is always in the science. It's just not the science. It's the caring about what you do. All right, thanks. And my advice is, as we move on, check out part 3 and any other Dr. Manny Learn Shops that are available on YouTube.